Prick, tingle, sting, burn, or ache. These are all signals to your nervous system that something may be wrong. Managing pain tonight on Call with the Prairie Doc. Hello, I'm Dr. Jill Kruse, your Prairie Doc host this evening. Tonight's episode is part of our 22nd season, providing health information based on science, built on trust. Whether you're having pain from activities, exercise, or chronic pain from medical issues, taking your health provider can be essential to finding a solution to help you manage your day-to-day life. Tonight we discuss just that, pain management. Joining us to address this topic is Dr. Eric Fjeldheim from Prairie Lakes Health System in Watertown, South Dakota, and via Zoom is Dr. Ptacek from Rapid City Medical Center. Welcome and thanks to you for joining us today in the studio here in Brookings. Tell us a little bit about yourself, Dr. Fjeldheim.
Yeah, so I'm a doctor of physical therapy practicing up at Prairie Lakes in Watertown, South Dakota. I've been up there for about 8 years now. And have really kind of taken on a special interest in the treatment of complex and chronic pain.
Excellent. So, Dr. Ptacek, tell us a little bit about your specialty and background.
I specialize in interventional pain, which mostly deals with medicine-free alternatives, injection therapy, implantation of devices to help block pain signals. I trained in Nebraska, did a fellowship in North Carolina, and then moved to Missouri for 5 years during COVID, ended up in Rapid City, and I love the Black Hills here.
All right, great. And I know your parents are both wonderful doctors as well, so you're following in the family tradition.
Thank you.
Yeah. All right. Well, before we start our conversation, we invite you, our audience, to submit your questions about pain management. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. To encourage you to ask early, all questions asked in the first 20 minutes will be entered into a drawing for our newest Prairie Doc publication. The winner will be announced at the end of this program. Your question will remain anonymous, but if you would like to be considered for the prize, please leave your name and contact information. Well, I have a feeling this is going to be a great episode because everyone has had pain at some point in their life.
Absolutely.
So it's very much a universal situation. So Dr. Ptacek, can you tell us a little bit about pain medicine doctors? What specialty do they usually have, or how does one become a pain specialist?
So pain specialists go through different sorts of residencies. My residency happened to be anesthesiology. So we're the ultimate pain experts in the operating room, oftentimes, rendering people asleep so they don't feel the pain of surgery. After anesthesia residency, there's a fellowship that you can go through, but neurologists can go through that fellowship, physiatrists or doctors who specialize on body movement can go through that fellowship. Primary care doctors can go through the fellowship. ER-trained doctors can also go through the fellowship. So it's a wide background of physicians that have a specialized training after residency typically do pain management.
All right. And Dr. Fjeldheim, tell a little bit about your specialty training in pain, because not all physical therapists have your level of training.
Right. So I did my pain fellowship through a continuing education company called Evidence in Motion. It's kind of this consortium of professors from different universities, or the main scientist that contributed to much of the content in the curriculum is Dr. Adrian Lowe, and he has over 100 peer-reviewed journal articles on pain science.
Wow.
And speaks at pain conferences in Spain and Valencia and kind of all over the place. Just happened to fall in love with a girl from small town Iowa, so our paths crossed kind of that way, and then I got bit kind of by the pain science bug, if you will, in 2018, and didn't look back.
All right. Well, as a girl from small town Iowa, I say small town Iowa girls are the best. So, all right. Well, viewers are coming in with questions. From an email, a viewer said, I hurt my foot years ago. What types of non-addictive pain medicine can I use when it starts hurting? Dr. Ptacek?
That's a great question. So we all know about the addictive pain medicines, and that's called the opiate class medicines. We try to avoid that class unless everything else has failed and there's not really much else to do. But there's typically 4 classes of medicines that we reach for, depending on the type of pain, before we even think about the addictive medicine. So the first class of medicine is what I would consider NSAIDs: ibuprofen, Aleve, naproxen. The prescription strength medicines are Mobic or Celebrex. The next class of medicines I would think of, depending if the pain has any muscular spasm, would be the muscle spasm medicine class. Next we have the anti-neuropathic medicines, or the membrane stabilizers. Those are the medicines that kind of slow down nerve pain if that's present in the foot. So those medicines are typically gabapentin or pregabalin. And then finally, we use a lot of antidepressants, so tricyclic antidepressants, or the newer generation, the SNRI medicines, are good at modulating a lot of the pain signals. We know that there's a big concentration of the mind and the body, and that connection is really important. It's important to kind of calm that down so we can normalize movement.
Excellent. So, well, Dr. Fjeldheim, there's a question that looks right up your alley. With the amount of sports kids are doing these days, are you seeing more injuries and pain from youth?
Dr. James Andrews is a big expert in the sports medicine and youth sports, and I think the general consensus is to try and minimize how much young athletes are specializing in doing one thing repetitively year-round. In general in healthcare, we're seeing chronic overuse injuries that may have been reserved for professional athletes. We're seeing these in younger people.
Is that why they're doing the pitch counts for Little League?
Totally.
Excellent.
Totally. That's why there's a lot of kind of safeguards starting to be put in place for soccer, baseball, football, you name it. And I think sometimes an interesting challenge with a young person that gets hurt is sometimes this may be the first time they've been confronted with a really disrupting pain in their life or an injury. So there's a lot of fear and angst that goes about that in treating these young people. And I find that if we can do a thorough evaluation and really explain pain to them so that they understand it, it makes it less scary for them moving forward.
All right, excellent. Well, Dr. Ptacek, they said, what are some other remedies for treating rheumatoid arthritis other than pain medications?
Rheumatoid arthritis can be definitely a big obstacle to overcome. It can affect a lot of the joints that you use to complete activities of daily living. So typically affects the hands. This is a condition where a lot of times we get our colleagues in rheumatology involved in treating them. There are some medicines called DMARDs, or disease-modifying agents. Those medicines can stop or help prevent the body from attacking itself. So first we'd want to optimize that therapy. And then there's certain nerve blocks and nerve pain medicines or NSAIDs that we could use to help treat that.
Mm-hmm. Excellent. So not just pain medications, but actually treat the disease, not just mask the symptoms.
Absolutely.
Excellent. All right. Well, a caller called in and said they had back pain 7 years ago and is wondering what medications or remedies can be used to treat his current back pain. So I don't know if this is like a re-injury or if it's been constant for 7 years. How would you do someone dealing with back issues, which is such a common?
Yeah, really the common cold of musculoskeletal aches and pains people can get. The vast majority of people have back pain at one point or another in their life, and a good amount of them will have a recurrence at some point or another. So back pain can have lots of different causes. There's many different structures and tissues that may refer pain to the back. It's really one of those things it's really hard to say what exactly the treatment should be without a thorough examination in this scenario. In general, we know that movement and exercise creates endogenous opioids, or nature's pain medicine, the good kind of opioids. So that's usually a pretty good place to start, is to try and move, as long as he knows that, or this person that called in knows there hasn't been a fracture or pathology or a kidney stone. I mean, any number of things could potentially be causing this recurrence.
Yeah, and I know even one patient we kept treating him for back pain. Turned out he actually had prostate issues. We treated the prostate, and then the back pain went away. Yeah. So, it definitely shows us that this body as a whole, and pain in one area could be showing symptoms of something being wrong in a different area.
Absolutely.
Yes. All right. Well, a caller says they have rib pain that radiates across the chest into the back and shoulder blades. She finds going to the chiropractor helps, but wondering if there's anything else that can be done for treatment. Dr. Ptacek, what would you recommend for, it sounds like very musculoskeletal in the shoulders and upper back?
Absolutely. Rib pain is a fairly common diagnosis, and there are a lot of referral patterns for this pain as well. So I would say if there's good response from chiropractic to continue that treatment, it might be worth it if the chiropractic treatment hasn't been helping, or the pain has been persistent for more than 3 to 6 months, to maybe see a pain doctor, or obtain an image to try to figure out what the source of the pain is. Once we'd identify the source, we'd have a lot of good options typically to help calm that down. The rib is a complex part of the body where there's a muscle attachment to another rib. That rib attaches to the backbone, and then there's lots of nerves that can be involved in that as well. So it'd be good to get an image and to see what's possible.
Mm-hmm. And I know a lot of people, when I was doing primary care, always asked about MRIs. When do we need to get an MRI? It's generally not the first thing we jump to. When is that appropriate to start talking about getting MRIs?
So MRIs are probably overutilized in medicine, but typically we think about an MRI when the pain's been persistent. So a lot of conservative care has been tried, over-the-counter medicines, physical therapy, chiropractic, or if there's any sort of warning signs, so sudden weight loss or fevers, chills, night sweats, a loss in a bodily function like bowel or bladder control, or pain that's also associated with weakness that shoots into the arm or the leg, that would be a good time to get an MRI.
Okay, excellent. So another viewer is saying they fell and hurt their knee. It went away quickly. Doctor called it a stinger. Is that something that can happen again, or what's a stinger? Do you want to explain that?
Traditionally, the use of the word stinger would be like a nerve stretch type of injury. So we see this in football when somebody goes to make a tackle and there's a rapid depression of the shoulder with the head bent to the side and a stretch on the nerves that come out of the neck and go down the arm. Traditionally, that's the common use of the word stinger, but it's normal to have bumps and bruises and aches and pains along the way. And the vast majority of them do go away as time goes on. In general, with a joint like the knee, we know that the joint surfaces, they get their nutrition and lubrication from movement. Like most big synovial joints in the body, movement helps to lubricate the joint and keep it healthy and happy. So again, as the physical therapist, my plug is going to be to keep her moving.
Keep moving, yes. All right. So from an email, should you go to your doctor before you go to your physical therapist first? Because I know some people can self-refer to physical therapy. Mm-hmm. So I'll let you both give your opinion on that one.
I'm very pro physical therapy first, mm-hmm. In the absence of warning signs. So in the absence of the things I talked about before, night sweats, fevers, chills, a severe pain that's associated with weakness, physical therapy is a great place to start. Most of the time, people get much better with just proper movement. And actually, we see a lot of kinesiophobia, which means fear of movement. So someone gets hurt and they're afraid of getting hurt again. And if they can have proper instruction with physical therapy, a lot of times they can prevent further injuries down the road.
Yeah, I mean, it always starts by screening out red flags or the big scaries. We start there. South Dakota is a state where there's what's called unrestricted direct access. So if you have an acre of pain or you shoveled and now your back's sore, you can get in to see a physical therapist. Usually, again, usually, you can get access to care a little quicker than if you have to wait, a month or so to get in to see a specialist or your primary care doctor. And there's been studies done. Virginia Mason is a kind of a landmark study where they looked at people that had back pain, and they put them on two paths: either go to rehab right away or go get an MRI. And what they found is that the people that went to rehab right away got better quicker and spent less money. So again, the key takeaway is, if you're going to go to PT right away, hopefully your therapist is doing a good job of screening for red flag pathologies. Dr. Ptacek alluded to the bowel and bladder changes if it's, a back issue that sometimes can cause that. But there's plenty of other, screening questions.
All right. So you both send each other patients all the time?
Yeah.
All right.
Teamwork.
Perfect. All right. A caller asked, said they had cataract surgery 2 years ago and are now having pain that radiates from the back of the head to the front of the eyes. Wondering if she should go get this checked out.
I think that she should get that checked out. There's probably a reason for it. Could be a positioning injury during surgery of one of the occipital nerves, one of the nerves on the back of the head, or a common thing that I see in my clinic is trigeminal neuralgia or atypical facial pain. So typically there's a medicine or a treatment that can make her life a lot better so she doesn't have to live with this painful condition.
All right, excellent. A caller says their feet hurt when they wake up, but are fine after they move around. Any recommendations for pain that happens first thing in the morning?
Yeah, we know that pain is produced by the nervous system, and we know that the nervous system, interestingly enough, it weighs about 2 to 3% of our body weight, but it consumes about 25% of the circulating oxygen in our blood. And what we also know is that over the course of nighttime, we're not really moving as much. We know that there's a drop in our systolic blood pressure, meaning that the oxygenated blood in the arteries has less passive push into the tissues, nervous system being one of them. A common thing I see clinically is that kind of first thing in the morning pain. If somebody takes a warm shower or they do some real gentle kind of movement exercises, things ease up as the day goes on, and life is good.
All right, excellent. So a caller says they have been dealing with shingles for a very long time. They struggle with the hot, sharp back pain, looking for treatments outside of gabapentin. Dr. Ptacek, if you saw this patient, would you have something to offer them?
Yeah, absolutely. Depending on where the pain is coming or shooting to. So shingles can unfortunately affect your face, your eye, your neck, your arm, around your ribs, even down into the legs. So depending on the dermatome, we know that shingles is typically caused from a virus that causes chickenpox, and it actually resides in a thing called the dorsal root ganglia, which is the offshooting of the spinal nerve onto the spinal canal, and it reactivates. And hopefully when it reactivates, it heals quickly and doesn't leave chronic pain. If it irritates the nerve a lot, it can cause persistent pain. So for that condition, if they were looking for medicine-free options, there's typically nerve blocks that we could do to calm the nerves down, or even spinal cord stimulation or dorsal root ganglion stimulation to prevent the pain signals from getting to the brain.
Excellent. So there are options besides just taking pills.
Absolutely.
All right, excellent. A caller says that they have bursitis in their right hip and have had 2 injections, but finds it still bothers them. They're taking Advil every night for the pain, but wonders, is that okay to use long term? Or what would you recommend they do besides the Advil?
Well, long-term use of NSAIDs has its risks of, stomach and GI problems. The thought process that I follow is more along the lines of what's called greater trochanteric pain syndrome. It's kind of this collection of, yes, the bursa lives over there on the outside part of the hip, or the lateral leg, but so does the gluteal tendons that attach in that area too. So there could be different structures. Maybe it's SI joint referral, lumbar referral, that could refer to the lateral hip as well. But in general, sometimes it's a positioning change that can help. There sometimes is a little pressure on those tendons in the bursa if people spend a lot of time with their legs crossed or they sit in a deep position. Even something as simple as putting a pillow or a bolster between your knees at night when you sleep can help to offload those sensitive structures and tissues. And then there's a protocol from Ohio State University that talks about a kind of a graded return to strengthening program. And usually you start with that tendon in a kind of shortened or less compressive position when you start strengthening the hip up.
Okay, very interesting. All right, another caller asked, they said they've had chronic nerve pain, have tried injections, but it doesn't work. Wondering what the next steps could be. So Dr. Ptacek, kind of hard to know where is this nerve pain, but in general, if injections haven't helped, is there another step up from that?
Absolutely. So we see a lot of nerve pain, depending on the source, assuming that there's no compression of the spinal elements that could cause nerve pain, or there's no metabolic issues like diabetes that's out of control, or some toxins. The most common cause of nerve pain is actually diabetes or excessive alcohol use. But assuming that we've ruled out all the metabolic or compressive disorders and simple injections aren't working, oftentimes we do a trial of what's called spinal cord stimulation. That's inserting a small electrode into the epidural space. The patient gets to try it for an entire week to see if it helps the pain. If it does work, then we can actually use a pacemaker battery hooked up to the electrode to actually give small signals to the spinal cord to quiet down the nerve. We have an amazing study which actually led to an FDA approval of this device for diabetic neuropathy in 2023. And the success rates are 80+%. People actually get a lot of their feeling back. They've shown that falls have been prevented. We think that actually we're going to prevent a lot of chronic wounds, because a lot of times when nerve pain is really bad, patients can't feel their legs and they are prone to injury. So there's really good treatments that are non-injection, non-medicine for chronic nerve pain.
Okay. Wow, that's exciting. That's very exciting. Yeah. Another email said that person has been having pain in their left hamstring for about 2 months. Until a week ago, it was mainly a nuisance. The pain has caused this person to limp, which has aggravated their degenerative disc in their low back. Last Friday, had a radiofrequency ablation to control the pain. This week, the pain in the hamstring has gotten worse. Can't find any relief. Starts physical therapy next week. What can you do to get that leg pain under control?
Yeah, I mean, with some of the things that were mentioned in that question, with the history of back problems and issues, we know that sciatic nerve kind of nuzzles right in along the hamstring. Mm-hmm. That would be something that I would try and screen and look at clinically in this scenario. And in general, again, nerves like three things: space, movement, and blood. So if there are those space changes in the spine, there's still two other things we could think about: the movement and blood flow piece. Sometimes some gentle nerve flossing can be helpful. Again, just thinking about different positions throughout the day that may increase or decrease the space for the nervous system. So yeah, I think that when this person goes to visit their PT, ask if they think that potentially there could be some irritation of that sciatic nerve along that path of the hamstring.
Yeah. Explain nerve flossing. I've learned a little bit about it. I find it fascinating.
Yeah, so we know that how the nervous system moves, it moves differently than how muscles move. We know that muscles shorten and lengthen. Mm-hmm. Nerves, if we look at them under, like we dye the nerve and we move an arm, we see that they actually kind of fold and unfold. But what it looks like on an ultrasound, so if you have it folded over, what it looks like is that nerve is sliding and gliding. So that's where the terms nerve flossing, nerve sliding really come from. It's the nature of how the nervous system moves. And it doesn't always kind of fold and unfold like we would think, and it's not the same in everybody. We don't necessarily have to know, like, oh, your median nerve moves this way on your, you don't have to necessarily know that specific, but there's different tests we can do to test the path of how a nerve runs and how sensitive it may be with different positions that we put somebody in.
All right, well, that is fascinating. A viewer called back and said, how long should the drug meloxicam be used in terms of pain?
That's a good question. So meloxicam is an NSAID class medicine. It's very similar to ibuprofen. It's safer than ibuprofen as it's very selective towards the enzyme that causes inflammation. NSAIDs have a black box warning by the FDA. It's their strongest warning for use after age 65. And that's because it can cause an increased risk of heart attack, stroke, kidney issues like kidney failure. And it can wear a hole in your stomach. So even though it's safer than ibuprofen, it's better to try to find other ways to manage the pain if it's going to be long-term use. And we actually have some research from the Journal of Nature from 2022 that shows maybe we're overusing NSAIDs. Maybe the body needs to swell at times with acute injuries, and NSAIDs are preventing the white blood cells from actually going in and helping fix the problem. So it would be good to explore maybe once a year to try to find some alternatives, and maybe meloxicam is the best medicine at that time.
Okay, interesting. All right. Maybe like a little drug holiday where you take off of it. I always tell my patients, I never want to put you on a medication and then just forget about it. We always need to readdress, are you having side effects? Are you having problems? Is there something better that's come out? Is there something newer? Is there something safer? It should never just be on autopilot and you've been on it for 20, 30 years and we never try anything else.
Absolutely.
All right. A viewer said, how do I deal with the constant throbbing in their hamstring area without relief in any position?
Oh, that's a good question. Usually, when we think about pain that's throbbing, we need to make sure we're screening out like a vascular problem that could potentially be causing symptoms in somebody's leg. So again, this is one of those without being able to get your hands on somebody and assess them and check pulses in their legs and go for a walk and see if that turns symptoms on, and then get them on a bike and see if that changes symptoms at all. You first, if for any type of like throbby type pain, like if it feels pulsating and throbby, we need to make sure we're screening out and making sure the vascular system is in good order first. But again, that back of the leg pain, there's many different structures and tissues that could potentially refer symptoms down into there, whether it's the areas from the lumbar spine, the SI joints, the hip. There's many different tissues. Sometimes, again, the bursa is usually more on the lateral or the outside part of the leg, but that kind of hamstring region, yes, you could have the hamstring causing some of that as well.
All right. Well, very interesting. So, a trigger point is a localized tender spot within the muscle that feels like a nodule, commonly referred to as a knot. Prairie Doc reporter Sam Schauer spoke to an anesthesiologist about the benefits of receiving trigger point injections and a change that happened recently.
Dr. Steve Frost of Monument Health is an anesthesiologist who helps patients with trigger point injections. He says it starts with a physical examination to find the trigger points.
Sometimes we get a local twitch response, that muscle actually contract by itself. Other is what's called a jump sign, which is exactly what it sounds like. The patient will jump when you touch it. And then sometimes they get what's called a referred pattern pain. It doesn't actually follow a nerve or dermatome level. It's just an area where that pain is.
After the trigger point is found, the injection follows. Dr. Frost says there are multiple ways to handle an injection.
Usually what we do is we inject local anesthetic like a dentist would use, with or without steroid, or you can use normal saline like we use in IV solutions just by itself.
Another injection used is one where you don't inject any fluid. Dr. Frost calls it Western acupuncture, or more commonly known as dry needling.
What happens is your own body sends its own mediators to actually relax, straighten out that muscle, and actually the increased blood perfusion over that trigger area will take away all the metabolic waste that's been stored up there since it's been contracting so long.
Dr. Frost says when injecting the anesthetic, the patient would receive relief for weeks or months. However, as of April 1st, 2024, Medicare changed the rules when it comes to trigger point injections.
A lot of my patients I would see on a every month basis, but now Medicare has, again, changed the rules, and they are only allowing us to do it 3 times a year per patient.
Dr. Frost says this has changed how he sees some patients. but one thing has remained consistent. Physical therapy is needed after trigger point injections.
If you don't use it, you lose it. And the whole concept is to break that pain generator cycle with the trigger point injection, relax the muscle, and have the therapist work with them in that affected area to where it does not become a chronic problem.
Dr. Frost concludes by saying the quicker a trigger point can be treated, the better the chances it doesn't become chronic, which he says is pain lasting around 2 months.
If that pain sensation continues, not only does that tight muscle contract all the time, but it affects the pain nerves that go to the spinal cord, and actually the spinal cord gets used to this signal, so it doesn't take much to cause a chronic pain.
Well, can any primary care provider give a trigger point injection? I know I did several trigger point injections as a primary care doctor. I don't know if all my colleagues felt confident with it. I think it's very doctor specific. Some people like to pick up needles and do procedures. Some are like, nope, that's not my cup of tea. What have you experienced, Dr. Ptacek? Do you get a lot of people sent to you by primary care that just doesn't feel comfortable with those?
Yeah, I think it just has to do with your comfort level and your training, honestly. There are some areas that are a little bit more risky in terms of trigger points around the rib cage because the lungs right there. But trigger points are generally very safe and very well tolerated.
Yes, I've done those and have had some amazing, they walk in the office in pain and they walk out with already some relief starting. So they can be very satisfying to do as a doctor. So you feel like you really helped someone. Well, we've got a lot of questions here. Like I said, pain is universal, so everyone has a question. From an email, a patient has had Harrington rods since 1984. Lately, they've had a lot of back pain and have been taking Tylenol. Is this a common thing getting older with a rod, or should they talk to their ortho doc about it? They're 74.
That's a great question. So Harrington rods was actually how a lot of scoliosis was fixed in the 1980s and early 1990s. So basically, it's a rod that extends through the whole length of the spine or the length of the scoliosis, and it's used to straighten the spine. So we know that whenever someone has spine surgery, whether it's with a Harrington rod or with normal fusion hardware, which typically people say are screws and rods, that the spine can be affected either above or below those surgeries. So I think it would be reasonable to first off meet with physical therapy and figure out if it's really coming from the back or if it's coming from a different joint, see if they can normalize movement, and then maybe take an image to see how much degeneration has been happening above or below the actual surgery site. It's common, it's very common for the spine to degenerate. It degenerates in 100% of patients, maybe a little bit more, actually at a rate of 4% per year more if you've had previous spinal surgery. So it'd be something good to get checked out.
All right, excellent. Well, I'm just going to keep going in questions because we've got more questions than I know we will have time for. So from an email, the patient's physical therapist suspects that their gluteal pain is coming from the spot where the hamstring attaches to the ischial tuberosity. Have you ever had a patient with this problem, and how do you relieve the pain? The MRI says no spine issue, so strictly that hamstring, that gluteal tendinopathy.
Yeah, I mean, where that hamstring connects, you can have kind of that insertional irritation of the hamstring tendon. Again, in general, where that runs, you're going to try and maybe limit excessive amounts of how far the hip is flexed up, because that puts pressure of that tendon as it inserts on the ischial tuberosity. And then again, usually just some combination, maybe it is, where you can do some nerve flossing. You don't always have to have an imaging finding for a nerve to be sensitive and irritated. And then usually, some form of, you can look at just the mechanics of the spine and how they move, or if they have, maybe a little hitch in their walk that maybe puts a little bit more strain on that hamstring. lots of different options, really. Even something like potentially dry needling could be helpful in this scenario.
Yeah. Do you want to talk a little bit about dry needling?
Yeah. So, it similar way of trying to treat like a tender spot in the muscle, like our trigger point. It doesn't, when we refer to a needle as being dry, it just means it's a solid filament needle. It doesn't have a hollowed out, it can't inject any medicine. But the theory is if you can stick that needle into a tender spot of a muscle, sometimes you'll elicit like a twitch response, and which is completely normal. You don't have to have the twitch response for the treatment to be effective. But for some of those muscular type of referrals, dry needling can be a safe and effective option. Again.
And that's something done by physical therapists?
Yeah, I mean, there's lots of different providers that can do dry needling, MDs, DOs, athletic trainers, PTs, PAs, chiropractors, I mean, any number.
All right, so a widespread technique with lots of applications. Okay. All right, so a caller has low back pain and hip pain. She heard about an injection into the cauda equina that could possibly help and wants to learn more information and learn if this applies to her condition. Dr. Ptacek, that sounds completely up your alley.
Yeah, so I think what she's referring to is probably an epidural injection. The cauda equina is a term where actually the spinal cord ends and the nerve roots begin. It's higher up in the low back. But typically, what we would do is figure out what nerve is irritated. The nerves, like I said, divide at the cauda equina, and if it passes through that area, if she has, the reflexes and the sensory deficit, and a straight leg raise that would support that, all the exam findings, then I think an epidural injection would be warranted, assuming physical therapy and other conservative cares have been failed.
All right. Can you kind of describe what is an epidural injection? We hear people talk about it all the time, but what are you actually doing?
Absolutely. So an epidural injection, people probably mostly think about, ladies in labor. So as an anesthesiologist in training, we did a lot of epidurals where basically we take a spinal needle and we use that to guide the needle into the space right above the covering of the nerves. And when we get into that space using a technique called loss of resistance, we're able to thread a catheter in. That catheter is connected to local anesthetic, and we can bolus that through to make the laboring patient comfortable. So in the pain world, we don't thread a catheter typically. We actually place the needle very precisely within millimeters of sensitive structures using X-ray guidance and some contrast. And then we inject cortisone or steroid through the actual needle to calm down the nerve. Typically, we give some numbing medicine with that too. Patients should have immediate relief if we inject the correct nerve. So it's a test that actually proves where the pain is coming from. And then typically 5 to 10 days later, the cortisone will decrease the inflammation enough where they should have long-lasting relief. Typically, epidurals are only considered a success if they last for at least 3 to 6 months. We have some data that repeated steroid use is not good. It can harm the body in numerous ways. It can affect your hormones. It can make your bones weak. It can cause insulin resistance, which could lead to diabetes. So we use epidurals very judiciously and to help with the severe pain so people can return to normal function.
All right, excellent. Well, while most people think virtual reality or VR is used only for games, medical professionals are looking into its value for chronic pain. One occupational therapist has been researching its uses and implementation in its practice. Prairie Doc reporter Sam Schauer discovered the use of pain reduction in VR and how healthcare is using more technology into its practice.
Nancy Baker is an occupational therapist and a professor at Tufts University who researches chronic pain. A while ago, Baker attended a conference that discussed chronic pain and the use of virtual reality and was amazed by it. She soon got a VR set to test on patients.
We put one of them in the headset with a program that they were in a space station, basically, and floating around in a space station. And this person had complex regional pain syndrome of the right arm. And As soon as she got into this headset, she started moving that arm normally.
Baker was astonished at the results and soon started researching how this could be used. Baker says the science behind it is called embodiment, where the brain perceives the virtual limb as its own and therefore can do more movement without pain from the real limb.
They've done experiments where, for instance, they've made the limb larger or smaller or painted it red, and people report greater pain or less pain depending upon how it's manipulated.
Her research soon shifted to finding fun games to play for patients to meet their goals, like playing Fruit Ninja.
We get people who have not moved at all whacking away at fruit and just having a really wonderful time doing it and practicing standing and moving more and just enjoying this opportunity to do something what they haven't done in quite a while, and often with this reduction in pain.
Baker says when patients take off the headset, they feel no pain in their limbs for an extra hour sometimes, though she has no research on why this happens. Baker also says combining VR and rehab activities can help manage chronic pain.
You want to combine the virtual reality with rehab that will allow you to learn how to self-manage the disease so that you're not living in a headset.
Baker mentions that this doesn't work for everyone, but says this gives an opportunity for patients with chronic pain to have fun again.
There aren't an awful lot of things out there that people with chronic pain can do that are just plain fun.
Baker ends by sharing that there is more research coming out about not just the use of VR for pain reduction, but for many other goals like exercising.
It is starting to grow. People are realizing how effective it can be, how fun it can be, and more people realize that it's not that hard to do. We'll see it being used more frequently.
Well, I think it's very interesting to see how virtual reality can be used for things other than pain management. I know in our hospice episode, we talked about using that for hospice patients, again, for pain control issues. So you said you've had a little bit of experience learning about VR with pain?
Yeah, so the group I did the fellowship with is partnered with a company called Behavior. And again, very similar. You're going in, you're exposing people to environments that are maybe calming or relaxing and having them move or breathe. There's one where they will teach people about pain, bringing in like a pain expert to help them understand pain a little better, maybe reduce some of the kinesiophobia that he was mentioning earlier. And there's been studies done in burn units where they'll have people put on VR headsets and then do the skin grafting that oftentimes is not a very pleasant experience for people, and it's tolerated much better.
Excellent. Well, that is fascinating. Well, viewers, we have received way more questions than we'll be able to get in the next about 5 minutes or so. So definitely tune into the radio show and we will try to get to all of those questions at that time. So definitely there's a lot of good questions here. One of the viewers is wondering when they should do warm compresses on bruises or injuries. I know that's a question, hot or cold? Both? Neither?
I think it kind of depends on the mechanism of somebody's pain and how acute the injury really is. And in this case, if it is like a hematoma on something, that's a different beast in and of itself. But we know that ice calms a certain fiber within the nerve called a C fiber that oftentimes will carry danger messages to the spinal cord. So you can think of it similar to, you could move your hand pretty crisp and clean, but if you go outside on a winter day without a glove in 15 minutes, you can still move your hand, but it's kind of slow and not as precise. So ice can help to slow the conduction of those C fiber nerves, and oftentimes that's important for pain. We also know that heat can dilate blood vessels, and people probably think I'm a broken record, but nerves like blood. Okay. So if you can dilate blood vessels in an area, that can help to calm pain as well.
All right, well, Dr. Ptacek, we have 2 minutes left. Any last thoughts or things you want to share with the audience?
Yeah, I think as a chronic pain specialist, I think something that is not touched on enough is the importance of the mind-body connection. And I think that VR segment was a perfect way to kind of transition into this. So we know the mind is really powerful, and we don't know exactly how it connects with the body. We know that patients' social states, patients' support systems are really important. And I would recommend a book for anyone who has chronic pain. It's by Dr. John Sarno, called The Mind-Body Connection. Very good book to help with that. We utilize a lot of psychologists too, with cognitive behavioral therapy, to help, recoaching and retraining and reframing how you think about the pain. I feel like that's a very valuable resource not touched on tonight.
Excellent. Well, I thank you both for this. This was a very informative show, and I think this definitely affects everybody at some point in their life. They're going to have pain, and I am so excited here. So let's talk about our winner for tonight. The winner of our prize tonight is Jeannie. Thank you, Jeannie, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
Have you downloaded and subscribed to the Prairie Doc podcast? Health professionals join host Laura Ellsworth each week to discuss and take questions about timely medical information. Search Prairie Doc on Apple, Spotify, SoundCloud, or wherever you find podcasts today.
There's an old joke where a man walks into his doctor's office and says, "Doc, it hurts every time I do this. What should I do?" To which the doctor replies, "Simple, don't do this." While that advice may seem trite and maybe even insulting, like most jokes, there is some truth in it. Pain is one of the ways your body tries to protect you from even worse injury. Pain tries to keep you from walking on a sprained ankle or lifting things with a broken arm. In those cases, the advice from the doctor is accurate. We cast broken bones to immobilize them and use splints and slings to rest muscle strains or sprained tendon. In these cases, excessive movement can make injuries worse. That break could go from well-aligned, where the bone can heal on its own, to displaced, where the broken fragments are now too far apart to heal and reattach properly. This could be the difference between having just a splint or a cast to needing surgery with plates, pins, or screws to realign and stabilize the broken pieces of bones. People who have decreased sensation due to neuropathy are also at risk for having something minor become a major injury. In neuropathy, the nerves do not send the signal when your pebble is caught in your sandal. That small pebble could continue to rub throughout the day and lead to a large blister or even an ulcer. Neuropathy can also cause pain on its own, as misfiring nerves cause a pins and needles or burning sensation, even when there's no external cause for the pain. Another condition called reflex sympathetic dystrophy, or RSD, is where the nerves are stuck in a loop, sending pain signals to the brain long after the initial injury occurred. This is a very difficult condition to treat. Fibromyalgia is also a condition where widespread pain occurs for no obvious external reason. For these people, the advice from the joke is not helpful. The typical pain medication used for broken bones or sprained ankles are also less effective. For patients with RSD or fibromyalgia, light activity with guidance from a physical therapist can sometimes help with their pain. However, too much activity can flare their condition and lead them to need hours or days to recover back to their baseline. Unfortunately, sometimes pain cannot be completely removed or fully treated. The goal then changes from trying to remove the pain to trying to remove the suffering associated with the pain. Ways of dealing with chronic pain need to be explored, such as chronic pain support groups and counseling. Pain specialists are also a good resource for these people, as they have more pain interventions than a primary care physician. So the next time you have pain, don't be afraid to talk to your doctor, because living with pain is no joke. Well, thank you to our guests, Dr. Fjeldheim and Dr. Ptacek, for volunteering their time to help us learn more about pain management. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, YouTube, and TikTok, or follow us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and listen to us live every Wednesday morning at 9:30 on KBRK Brookings. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thank you for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Regular pediatric care is a vital part of not only keeping your child well, but also providing guidance throughout your child's development. From birth to adulthood, pediatric medicine. Next time, On Call with the Prairie Doc.
My name is Tom Dean. I'm a volunteer board member for the Healing Words Foundation. I grew up on a farm near Wessington Springs. Actually a farm that was only a few miles from where my great-grandfather homesteaded, so our family roots are deep there. I went to high school in Wessington Springs and then to Carleton College in Minnesota, and from there to medical school in Rochester, New York. Access to health services is quite limited, so the Prairie Doc activities allows people to have contact with medical professionals from a variety of disciplines. The uniqueness is the fact that it's independent, it's not associated with any of the various competing forces that sort of control health services today. It's objective, independent, and I believe reliable. I think having access to health information that people really do trust is a tremendously valuable service, and that's true whether you're in the prairies of South Dakota or the middle of New York City. For more information or to donate, head to www.prairiedoc.org or send your donations to Post Office Box 752, Brookings, South Dakota 57006. Thank you for your support.
Major funding for On Call with the Prairie Doc has been provided by...
Out here, the day starts early and ends late. You don't love this land because it's easy. You love it because it's home. At Avera, we're built for rural healthcare. We're bringing quality, innovation, and advanced technology to your vibrant communities. Care when and where you need it. That's how Avera moves health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health, Dakota Dermatology, Vance Thompson Vision, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Sioux Falls District Medical Society, Yankton District Medical Society, Orthopedic Institute, Aberdeen Asthma and Allergy, South Dakota American College of Physicians, Cool Beans Coffee, Lake Poncet Sailing Academy, and Swiftel Communications.